Hello and welcome to Value-Based Care, a panel discussion with industry thought leaders. I'm Carol Flagg of Answers Media Network. Thanks for joining us today for a conversation on where the healthcare industry stands on the move from fee-to-service to value-based care and what the future holds. Answers Media Network, of course, publishes a series of topic-driven websites and multimedia channels dedicated to covering the current issues driving change in healthcare delivery. We also own and operate Healthcare Now Radio, a streaming 24/7 internet radio station that offers interviews and commentary from industry leaders in healthcare and health information technology. In 2018, the station will hit over 300,000 listening sessions. You can learn more at www.healthcarenowradio.com. And now, I'd like to introduce today's moderator and panelists. Back with us again to moderate the discussion is Fred Goldstein, president of Accountable Health LLC, where he provides consulting on population health and value-based care to healthcare systems, IT companies, pharma, and startups. Fred was also recently appointed to the graduate faculty at the John D. Bauer School of Population Health. He also hosts Pop Health Week, a syndicated radio show we air on our own Healthcare Now radio station. Joining Fred is Jay Eisenstock, a seasoned consultant, speaker, contract negotiator, and management professional with more than 30 years of recognized experience in healthcare and technology. He is the chair-elect of WEDI, a commissioner for the Electronic Health Network Accreditation Commission, or ENAC, and serves on several committees with the Council for Affordable Quality Healthcare. He has also been recognized by Healthcare Payer News as one of the 11 top executives and thought leaders in the healthcare IT industry. Also on the panel is Timothy Mills, the Chief Growth Officer of Alpha 2, a company providing solutions for coding, compliance, claims editing, and revenue analysis for healthcare professionals, clearinghouses, and government entities. Tim has extensive experience in clinical, financial, and administrative outsourced technology services, as well as turnkey solutions to the provider, hospital, health system, and health insurance marketplaces. He is also an active member and speaker with MGMA, AHIMA, HIMSS, HFMA, and HATA. And rounding out our panel is David Muhlstein, Chief Research Officer for Levitt Partners, where he directs the study of accountable care organizations and leads the firm's quantitative evaluation of healthcare markets. David also serves as adjunct assistant professor at the Dartmouth Institute at the Gesell School of Medicine at Dartmouth College, and is a visiting policy fellow at the Marvelous Center for Health Policy at Duke University. He's also a visiting fellow at the Accountable Care Learning Collaborative. And now I'll turn today's roundtable discussion over to our moderator, Fred Goldstein.
Thank you so much, Carol. And Tim, David, and Jay, welcome. Glad to have you on today.
Thanks for having me here.
Oh, it's our pleasure, and it's a fantastic panel. Very excited about this. I'm actually out at the Health 2.0 conference here in San Francisco or Santa Clara. You know, supposedly the center of everything new in healthcare and IT and all that stuff. And what's been fascinating is this morning they actually spent about half of it so far talking about value-based care and what it's going to be doing and how you play with it. So coming from a conference that's really focused a lot on these little tech innovations or areas of new stuff, it's fascinating to see them begin to look at value-based care. So I think this should be very exciting. And as I sent them out in a tweet earlier today, unfortunately they can't listen to this, but they could sure listen to it after it's been recorded. So I hope a bunch of them also get involved with that later after that comes out. So perhaps, you know, as we think about value-based care, there's been a lot going on. And more recently, and David, obviously you did a wonderful 1 hour for a class I'm doing on ACOs to kind of introduce what's happening with the status of ACOs, what's going on with MSSP, et cetera. Could you sort of begin by giving us a little bit of background and then lead us to where we are today from the work that you've done with Levitt Partners, et cetera?
Sure, happy to. So when we think about value-based care, there's two big buckets. One are episodic models, so these are the bundled payments where you're responsible for a single patient, and then you've got the population-based models where you're responsible for the total cost for all the care that the patients receive. And you know, when I think about these, I think that they actually work really well together because the population-based models have the incentive to lower utilization. The episodic-based models are designed that when you are doing something, you better do it more efficiently. But we're tracking both of these, but the ones I think that we are more exciting are those on the population health side, and that's because it's really rethinking how you deliver care. Episodic ones are really trying to break down some silos, but it's a similar workflow. But when you're looking at it from a population perspective, organizations are dramatically rethinking care delivery and really trying to think of how they should deliver care in a fundamentally different way. So when you look at the total growth of these, our most recent numbers put the number of ACOs at just over 1,000 and covering about 33 million lives. And that's 10% of the population, which is a lot. But to put it in perspective, at the peak of the HMO movement, there were about 90 million people covered by an HMO. And we know when there was major consumer pushback in the early 2000s, that number just petered down. And that could happen with ACOs as well. If there's a lot of consumer pushback or a lot of organizations fail, just can't make the transition, things could get pushed back and they could go, I guess it's kind of recidivism, go back to fee-for-service, the thing that they're comfortable and familiar with. But we've seen a few results that are pretty encouraging. So one of those is just looking at how well organizations perform the longer they've been participating in an ACO. And the most recent results for the Medicare Shared Savings Program were that those that have been in the longest, so those that have been in since 2013, about 60% of those organizations are now to the point that they're getting bonus payments, so saving enough money that they're actually below the minimum savings threshold and getting these payments. Those that were only in their first year, about 20%. And so we're seeing that over time organizations are starting to figure this out, and I think that's a real key to this, is that payment reform is important. It's hard, it's challenging, but it's delivery reform that makes the difference. It's how do we fundamentally change how we engage with patients. And that's where the ACOs are starting to figure out over time. And there's lots of barriers to that, which we might get into later, but I'll tee up the biggest one, and that's just people. It's really hard to get people to change. You know, change management is something that we've dealt with since the dawn of humanity, the dawn of civilization, and it's no different in healthcare. If anything, maybe it's a little bit harder in healthcare. People want to do what they know, and they know RVUs and fee-for-service and volume-based payments. But trying to move away from that, it's about getting people to see the vision, see the opportunity. And then secondly, it's building that business case around it. And that's one of the challenges that I see is that, sure, you can come up with a lot of things that would be better, and you'd lose money doing it. So how do you fundamentally create a winning business model in addition to a care redesign? So that's where we're at right now, kind of a quick overview.
Fantastic, David. And as you think about, you know, value-based care, et cetera, obviously you can't do this stuff without data. And we've got all these various systems out there and disparate data. So Jay, with your work at Weedy, where are we in terms of being able to connect enough of the groups of providers to begin to efficiently pull that data together, analyze it, produce actionable results and information that's useful?
Well, in a word, it's still a challenge, but if you think about it, it wasn't all that long ago where the relationship between health plans and providers was strenuous at best, right? And one of the good things I think that we're seeing as we start to change the payment models is there's a real need for collaboration to be able to help patients, which is really what it's all about from both sides. And I think as a result of that, we've seen a lot more collaboration and a lot more opportunity to share data, but we have challenges. We have a lot of disparate systems, which I know we'll get into a little bit later in the discussion today. But you know, a lot of the systems from the health plan perspective, as an example, were built around fee-for-service. And then even though most provider organizations today are using EHR systems, those were really clinically based to begin with. So we have a disconnect really out of the gate, and it's been a challenge to be able to exchange the right data at the right time about the right patient.
Mm-hmm. And so if you think about this then from that broad perspective of linking up these external systems, and we start to say, okay, we have, you know, within the ACO and getting that information out to the patient or out to the doctor, the care manager, Tim, what's the status of that and in terms of that kind of integration and analytics?
Yeah, great question. I think that as it relates to, you know, really the integration itself and then the analytic systems, I mean, I very much agree with David and Jay. The challenge is pretty significant, and it's actually not a simple answer or really a singular answer, especially when you consider the providers across the continuum of care. You've got everything from the small, medium-sized practices to very large clinics to the integrated delivery networks and literally everything in between. So certainly, and the various HIS and EMR and RCM vendors, you know, certainly play a lot of the important aspects, you know, in that best-of-breed solutions, single-source solutions, a variety of different scenarios. Kind of even goes back to what David says. You know, a lot of it really, to me, rolls through How can you implement change? Certainly, the usability piece, as it relates to the ability to make it functionally usable versus actually being used in the real world in the workflow, and when you're engaging with patients and dealing with all the other administrative realities in both institutional and non-institutional settings. It comes back to, we're from a technology perspective, we are certainly, over the years, have been very quick to adopt technology in the care of patients. But as we talk to clinicians over and over, the slow adoption to the usability piece as it relates to the technology, it's not just data integration and not just the analytical systems that are available. It's what does it do for me? Does it actually save me time? Does it, number two, does it affect my outcomes, right? And number three, does it really affect my reimbursement? So looking forward to kind of this dialogue and understanding and kind of marrying the differences between some of the technical models that are there, and certainly integration is there, but it's how do you drive that from a technical availability into a usable model?
Mm-hmm. And when you think about usability and this technology coming together, we see these, as you mentioned, David, we have certain number of individuals in ACOs, in these value-based contracts, but it's nowhere close to the HMO penetration we saw back in the 90s. Is there enough support and readiness to keep this thing moving along? And is there major disparities perhaps between those that pay for it, such as the CMS and the employers, and those that are providing the service? Or are they getting a little more in lockstep?
Yeah, definitely not in lockstep yet. I think there's different organizations that are better positioned to move this along and those that are worse off. And I'm actually really bullish around the physician-led organizations, and it's because their business model is, let's care for this patient population. We're going to start with them, and we're going to provide a lot of outpatient care. And that means in the short term, we're going to increase our fee-for-service revenue based on that. We're then going to eliminate hospitalizations, and then we're going to save money at the end of the year on this bonus payment, because we're going to take some money, and in effect, they're taking the money away from the hospitals. Hospitals tend to say, well, let's reduce our post-acute care utilization, so let's take it out of the SNFs or the home health agency's pockets. It's always about, how do I do more, but somebody else is going to kind of lose that volume. I think, though, that there's a real mindset shift that needs to happen, and it's around understanding what the real opportunity is to rethink healthcare delivery. And it's the challenge with all of these is people are starting with fee-for-service with the assumption that if I do more, I get paid more in the short term. I just want to take the fee-for-service dollars away from somebody else. So historically, there's something that we call it from volume to value, but I think more articulately or accurately, it is a capacity-focused worldview to a needs-based worldview. So a capacity-based worldview is you say, let's start with all of the services that are out there, identify the ones that are the best reimbursed, build capacity around that, and then fill that capacity. I mean, it's basic business school. Let's build heart hospitals and oncology care centers and ambulatory surgery centers, the things, the procedures that are well reimbursed. Let's build the capacity and then fill the capacity. And you look at the organizations, a lot of these hospital systems, and how do they build new hospitals? Well, they go and take bonds out. Some of them are corporate bonds, some of them are community bonds that are tax exempt, but they're basically are committing to a 30-year or a 50-year, or in at least two cases, a 100-year bond, where they're saying, we are committed to this capacity-based worldview. If you stop using the hospital, you can't pay your mortgage payment on your bond. Technically a bond payment, but it's like paying your mortgage. Under a needs-based model, you say, let's start with the population. Identify what the needs are for that population, and then figure out how do we provide those services at the lowest possible point or cost point. And it is a radically different worldview. And so the organizations that I think are really fascinating are the ones that say, let's just ignore this capacity-focused model and let's start over and let's kind of build it from scratch. And so these are organizations like CareMore or Landmark Health or Oak Street Health that are these physician groups that say, let's start with the needs and then build everything else on top of that and say, what technology do we actually need to effectively manage a population? What are the skill sets that we actually need, as opposed to saying, what can we kind of loop in with this capacity that we've already been dealing with for the past 30 years?
So as you look at that from a tech perspective, Jay, and then maybe perhaps Timothy, when the doctors have always had a little more of an issue because it's affordability for that, because they're not bringing in these huge chunks of revenue. So you see these systems that are hospital-based versus provider-based, but the provider-based and the physician-based have shown better outcomes. Is there something that other physicians out there should begin to look to or should consider as they say, hey, we'll go ahead and build this because we know that model may be more successful?
So I like the way David categorized it, and one of the things I like to say is, technology should be an enabler. So we have these new models where we're looking at what's the right business process and then to automate that as opposed to just create the technology and, the old adage, build it and maybe they will come kind of thing, which is typically what we've done, unfortunately, within the industry. So I think that there's some great opportunity here to take that step back and to look at, what is the most effective way to be able to do data exchange. One thought I'll put out there is, several years ago under the HIPAA regulations, we had some very defined standards for things such as claims. And that works well in a fee-for-service world. But if you think about it, do we need that same kind of structured claim data in order to be able to support, these new payment models? And I could argue that we don't, that there should be ways to more interactively share information between physicians, between care service organizations, and even health plans. So I think this whole new world calls for us to rethink a lot of what we've taken for granted, and frankly, I think that's a little bit scary and challenging for many in our industry.
Your thoughts
absolutely.
on that? Yeah.
Yeah, no, I very much concur, and I love the mantra of rethink. We've been talking a lot lately about literally rethinking everything around the reimbursement system, because we really do need to kind of go back and even take a look at some of the old data models. As you mentioned, Jay, the importance of the so many years of just different types of data models takes me back to my my care science days in the early, the CHIN, the RIN, the RIO, the early stage health information exchange marketplaces. Literally trying to deliver technology for technology's sake, really good technical models. Let's build a repository in the sky. No, that's not going to work. Let's build a virtual repository. So I think it's some combination of, again, finding that balance between how do you take advantage of technology, but turn it into a way to where it also mirrors the reality of workflow, best practice, physician offices as well as hospital settings. They have significant administrative challenges, and so where do you spend that time? The reality is that you've got to follow the money. Fee-for-service is likely not going away. So how do you blend the two together? How can we be successful in being able to bridge fee-for-service and perhaps also even identifying qualifying events earlier in the workflow and kind of bridge that gap in those environments? So it's a challenging environment, and literally at every level, not just at the provider level, but even as we engage patients. Patients begin to need to start thinking differently and acting differently and engaging more, in the disease state and the disease environment.
Got it. And right now, David, we obviously have CMS saying we're going to move you along quicker in terms of moving to two-sided risk. But we have these organizations, maybe some of the healthcare systems built around hospitals that are less successful at operating in that. And at the same time, we still have a huge chunk of fee-for-service, but you really don't practice in two different ways. So are we going to see those groups sort of pull out? And will that slow this trend?
Definitely could. And the challenge is really trying to make a business case around this. And so the idea is that when you change care delivery, you change it for all your patients. And so let's say you really effectively manage people on an outpatient side, you reduce your hospitalizations, and so your average daily census drops by, say, 10%. So you get your CFO to run those numbers, and it's like, yep, sure enough, doesn't make sense for us to drop our average daily census by 10%. And so the challenge, though, is can you get enough lives that are under a risk-based contract so it actually does make sense? Because if you're fully capitated and you can reduce your ADS by 10%, you're happy. But what will it really take to do that? And what we've seen is a lot of organizations at this point, particularly I would say the large health systems, they're in an experimentation mode. And so they put a subset of their population at risk. So they go and work with just the shared savings program. They just have maybe, a handful of primary care practices that are included. They might get 10 or 15,000 lives initially that are at risk. If you look at it, this hospital system probably does 1 million inpatient and outpatient visits over the course of the year, probably treats several 100,000 different patients. And you say, so what can you do with 10,000 patients? You sure can't make the business model where it makes sense to lower the volume. And so what needs to happen is you need to get sufficient breadth of risk that you can actually run the numbers and show that it makes sense. There's an ROI to reducing the utilization of these services. And it depends on the size of the organization, and it depends on kind of your payer mix. But we think it's probably from the 30 to 50% range that you can actually make a business case around that. Most organizations have below 10% of their revenue through these population-based models. For those that we're even tracking, they're pretty far away from it. And one of the challenges you brought up earlier is there's just not alignment between the providers. One of the things I like to do is say, okay, you're involved with a number of different value-based payment arrangements. How many different A1C measures do you have? And I've had ACOs that have up to 8 different A1C measures. And it's like, why can't I just take care of a population? Why do I need to know which specific benchmark is safe for this population? And quality measures are all across the board, but also the attribution models and how you do comparison groups and risk adjustment and all of these different things makes it really challenging from just a managerial perspective to really manage these programs. And I think that's going to be a barrier. Until we start to get alignment across payers, people are just going to keep doing it at that demonstration level unless it becomes mandatory. And the only time it's been mandatory so far is really a handful of states that have pushed their Medicaid populations to it. Medicare can't make it mandatory, at least anytime soon, and commercial payers just don't have the market power to. And so a lot of experimenting until you increase the breadth of the programs, but until the programs are kind of more uniform, you're just not going to see that uptake. And so I think that's the barrier right now.
So that obviously creates sort of this cultural and perhaps a technological barrier because you're having to report back so many different measures for the same condition. Has that been something you've seen, Tim, in some of these facilities or systems that they're reporting back 6 different quality measures for one specific measure? And is that something that's pushing from a technological approach as a difficult issue?
Well, I think again, it does go back to the realities of that and being able to, from an availability perspective, how do I select the appropriate measures, and what measures do I choose, and what's the format, and all of the different aspects that David had already mentioned. Yeah, that is really very much a reality in those settings. What technology is available, where in the workflow, am I able to get a better appreciation of that? How do I apply those? How do I engage my patients? The Honda patients, the hypertensive, obese, non-compliant, diabetic, asthmatics, those patients where we're spending literally 70% of the healthcare dollar. How do you find that balance of actually getting them involved in the process and perhaps even working towards getting rid of at least one of those acronyms, which is the N, moving them from non-compliant to moving them to compliant, which makes a significant difference both in driving, true value care, but really getting the patients involved in that process. And I'm eager to, continue this dialogue today, especially as it relates to how we bridge that over more so to the patients and being able to really see them as a part of really accountable care. Accountable is a relative term, so let's bring in accountability, across the board, both the payer, the provider, and the patient. Make sense?
So from that perspective, Jay, are you seeing any interesting approaches to engagement of individuals or patients, or getting them more involved in the system as a piece of that network?
So not enough, right? And I think what everybody's been talking about is the lack of consistency of those data requirements. One thing that's exciting about a time that we're living in is if you look at, whether it's the recent announcements from Apple and others, there's a lot of capability that's literally in the hands of patients today that could be useful if used correctly and used in a way that patients want to engage. And so I think that's an opportunity as well as the challenge. And, you know, I think the other thing that we struggle with when we talk about the data requirements piece of this is that, yeah, there's different plans, and even, you know, Medicaid and Medicare have different requirements for all the elements. And if you put yourself in the shoes of that provider that's trying to support these things, you know, it becomes a real challenge to understand, you know, what kind of data is needed for whom and when. And, you know, at some point, especially if the ROI is maybe not quite there, I think there could be this sense of just throwing up their hands and saying, you know, this isn't going to work.
So if you think about this, it's going to work, it's not going to work. There have been some successes. David, you pointed out at fourth year out, we're starting to see better results. But you also made the comment that you really need more lives to begin to get that done. So what are the factors that organizations should consider to be successful? What do they need to start to think about and look at? And also, perhaps, are there any things we can rule out or models that just don't work?
I don't know about models that just don't work, but there's a few factors that are really important. And the first one is it's going back to the people and its leadership. And it's somebody that recognizes that this is the future. It's better for the company long term. It's better for the patient. It's going to make the providers happier. But recognize that you need continuity and consistency in leadership and keeping your eye on that prize for the long term, because these organizations don't transform overnight. So there are a handful that have done this previously. So for example, some fee-for-service-based health systems that basically got the majority of their population moved to capitation, and kind of out of necessity they had to make this same transition. It's probably, they say, about a decade. And so really, to transform your organization, can you have consistent leadership with that message for a decade so that you're really moving toward that? That's a challenge. That's the hard part. A second big one is really getting the contracts aligned and getting them right. There are a lot of examples of organizations that just said, we want to form an ACO, and they go to the first payer that's going to throw a contract their way, and they have no idea what they're getting into. And so they sign something that maybe is great, and other times it's absolutely awful. But really getting a sense of what they're getting into and how they're going to start to approach this. And that's getting those financial models to start to align. So consistency and doing it over the long term. Third one is leverage any sort of a burning platform that exists within the organization that's driving change. And this can be something as simple as, you know, there's going to be new statewide licensing requirements for physicians that make you look at things in a new way, and you use that as sort of a leverage. Maybe the hospital or the health system or the physician group has struggled financially, and you say there's actually a willingness to make some modifications just because, you know, we're not doing as well as we have in the past. Maybe it's the board, where the board says, we actually see the future, and we want you to start to move, and we're going to start evaluating our CEO not based on their margin, but if they're able to actually lower the total delivery cost of care. There could be all sorts of things that start to kind of spark this change, but you've got to be patient, and it's not something that changes overnight. So these organizations, it's got to be commitment to that idea, keep your eye on the prize, and just figure out all of these problems. Because when you're redesigning and rethinking a healthcare system or healthcare delivery process, there is just a million little things that you're going to have to figure out along the way. There's no kind of magic cookbook that you open up and says, these are the 3 ingredients, and then mix and cook for 30 minutes, and then you're going to have an ACO. You got to commit to this, and it's a long process. So that patience, I'd say, is a real key.
And you mentioned something interesting just around contracts, and I was talking to a buddy of mine who's running an ACO, and he's got Medicare, Medicaid, and commercial, and he said 2 out of 3 are doing great, but I made a fundamental error in my contracting for my Medicaid contract, in that when I set up for my reinsurance, instead of setting it up at $100,000, you know, anything in excess of $100,000 for an individual during the year, and I don't pick it up, it was per admission. And so major difference in how that gets, and that's what did it, you know, from a financial perspective. So as you talked about, thinking through those contracts is critical, and understanding what they've given you, and maybe getting the expertise to understand all of those different variables, because maybe you haven't worked as much in this space because you've been in that fee-for-service world. So as you think about this from a provider perspective, and we talked a little bit about culture, what about from the IT side? Are there things that the more successful players have done or are doing versus those that maybe are less successful?
Yeah, I'll give a few ideas, and it'd be great to hear how Tim and Jay think about these. So I'd say the first one is they figure out what works given the needs of their organization. So one example is a Medicare Shared Savings Program ACO that did very well, and they're small, about 20 or 25 physicians or docs that were a part of this practice. And what they did is they got two guys, and they just have these two tech guys that have kind of figured out and cobbled together a solution that works for them, because they tried a few off-the-shelf things and that just didn't work. I've seen other ACOs that on day one, they came together with a variety of different hospitals and physician groups, and they said, we're going to transform things together, and they had over 50 different EMRs, none of which spoke to each other. And they said they spent their first year just figuring out how to share basic information. I mean, they were literally just relying on a fax machine to get things back and forth. And so that's the first one. Figure out what your needs are and what works in the short term so you can start seeing some of those successes. Another one is it's the whole concept of milk before meat. You hear ACOs that say, we need to go and get a really robust population health platform. We want to segment our population. We want to identify all of our diabetics. We're going to do all of this preventive care and things. And it's like, it's great to have that, but if you don't have the boots on the ground that can actually operate on that, what good does it do? And so we see people that have made these investments that they're just not paying off, and they say, it's because our platform's wrong. No, it's not the platform's wrong. It's that the organization wasn't ready for it yet. And so do an honest assessment and say, where are you at, and when are you going to be ready for that? Third one, and this is, I would say, it seems almost intuitive, but it's something that we've seen a lot of organizations that have avoided, and that is learn from your peers. And what I mean by peers are organizations that kind of look like you. Find out what they've done, and even more importantly than what has worked, find out what hasn't worked, so you don't go and repeat those same errors. There's kind of an attitude that we've seen across healthcare that everybody wants to reinvent their own wheel. Don't do that. Learn from the people that have done it before, that have similar problems, and build off of the success that they've had to date so that you can start to figure out what actually you can see that short-term difference.
And your thoughts, Jay, on that?
Yeah, I like a lot of what David said, and the other thing I would add to that is what we've done sometimes is we do overload, especially on the physician practices. There's just so much data that's being thrown at them or asked of them, and it's frankly unrealistic for them to be able to comply with all the data that's being sent to them, and it doesn't move the ball down the field. And so I like David's approach of talking about doing some pretty simplistic things to get the ball rolling, not over-engineer it. Try to keep the focus on the patient and what is really needed, and not spend millions of dollars to build a fancy system that may not meet your needs just because it's shiny and new.
Mm-hmm. Right. And Tim, have you seen some of those more simplistic approaches, and what might they be?
Yeah, that's a great question. I don't know.
Oh. Go ahead, Tim.
Sorry. Yeah, no worries. Yeah, no, I just was going to say, I think that, that you really hit it on the head there. I think that it relates to certainly, what's the definition of insanity? Doing the same thing over and over and over and expecting different results, and learning from things that have peers and others that are doing things well, and yet feeling like that you have the ability, to step in and put some best practices in place and move forward to be able to facilitate those more effectively.
And, you mentioned this earlier, David, and we've all sort of touched on it different times, this move to capitation. You mentioned Oak Street and some of those. Everyone talks about that being the end game, but I guess we'll probably have a stretch between still having fee-for-service all the way to cap. And if you're going to capitation, what do you need to be considering?
Yeah, so I would say that it is going to be the end game for some organizations and probably some regions of the country, but I actually think that, different markets will play out differently. I think of healthcare as the $3 trillion cottage industry, and, what's going on in Seattle is very different than San Antonio. And understanding kind of those market dynamics, there are some markets that it makes sense to move to capitation, others probably not. You can effectively manage patients in a different way and maybe stick with fee-for-service, and that can slow down, or you can manage the cost growth there. but it all depends on those local market dynamics. So under a capitated environment, the thing that you have to be better at than anybody really is now that's under a fee-for-service system, just because it's not asked of them, is understand the needs of their population. How do you identify who you should be focusing on? Because you can't put the same amount of resources toward everyone. And just being able to segment them. So you might look at it and say, oh, it's over 65. Obviously, I've got to worry about diabetes and heart disease. Well, maybe. But maybe COPD is really where there's a big opportunity, because those are where the costs are. Those are where people aren't appropriately managed. Maybe it is diabetes, but is it all diabetics? Maybe it's a subset of that population. And getting to the point that you can understand the needs of the population is going to be key. The second, and this is often overlooked, particularly as people are thinking of capitation, because they say, well, once I'm taking full risk, I'm also caring for that patient. I'm doing all that delivery of care. But the reality is that very, very few organizations are providing all of the care. Typically, you need to have partnerships. And how do you create high-value partnerships and meaningful arrangements so that you can bring in those services? Examples of this are things like pharmacy. So are you effectively managing the pharmacy? Are you doing it from an inpatient standpoint before people are released from the hospital? And then what about from retail? Pharmacists see patients significantly more often than physicians see the patient. So what can you be doing with those trained clinicians? Second is post-acute care. We talked to a lot of ACOs that say, yeah, we know that we need to be doing more with post-acute care, but we just don't have the efforts. And so what they'll do is they'll download the list of the SNFs in their market and look at their star rating on home or on SNF Compare from CMS, and basically just kind of prioritize on that, really having no idea if that rating matches the patients that they're sending, or if there's certain ones that there's differences and the like. Third area is mental and behavioral health. Very few providers are well positioned to provide all of the mental and behavioral health services that are needed. But if you don't address those, then it will lead to very high clinical costs or acute care costs that are associated with that. But very few providers are really in a position. Somebody that's struggling with substance abuse, for example, how do you actually go and treat them? Primary care docs aren't in a good position to do it. You need dedicated specialists to do that. So after you know what the needs are for your population, how do you start to create those partnerships and design them in a way that you can have successful interventions that will ultimately eliminate some of those potential costs? But if you can't do it, you know, the story I've heard is that you can do a lot of good for 1,000 patients, but if you miss the $1 million case, it doesn't matter. How can you make sure that you never miss that $1 million case?
Mm-hmm. And how does, you talked about different groups, mental health, you talked about pharmacy, you talked about SNF. So Jay, obviously pharmacy tends to be fairly well integrated from a claims perspective, et cetera. What about some of those other provider groups? Are we at a point where SNFs are beginning to get enough connectivity and data and other post-acute care providers or mental health that they can integrate their systems to be able to better coordinate that care?
But we have a lot of work to do there, and I don't believe we are. And you know, again, to David's point, one of the things that, you know, is often talked about, but I'm sure there's really not any good answers, is, you know, the environment plays such a key role here, right? So if a person is not eating the right foods, it's going to have a huge impact on, you know, their compliance with whatever regimen their physician has put them on. Similarly, if they can't get to an appointment, that's also going to be a challenge. And so you see things like Uber Health and some other partnerships that are helping to try to bridge those gaps to ensure people have the right services at home, which is where a lot of people are actually being cared for, not only by themselves, but by family members or other caregivers. I think those are all important actors in this whole equation, and no, I don't think we're at a point yet where we have the right tools, technology, or resources to be able to address that.
So this whole issue that you sort of have led into is the social determinants of health, hot topic right now. Everybody's saying we got to go after the social determinants of health. At the same time, as you pointed out, David, maybe, and Tim, maybe you need to be really simple. So are we just overloading the system by saying, well, now we want to integrate all the SDOH data in here, and how do we integrate that, and what does that data mean? And as you pointed out, how do you then use it and do something actionable off it? Is it creating too much? Any thoughts, Tim or David or Jay?
So I'll jump in. So I do think that there's a data overload where people just don't know what to do and they don't know how to find the identifiable interventions. Turns out that there are a lot of things, these interventions that you can do that really don't make a difference. And one of the challenges that I've seen with a lot of organizations is that they make decisions based on anecdote. It's like, well, we put together this program and I have one really compelling story, what happened with Mrs. Smith, but when you actually run the numbers, you find out across the board it didn't make a difference. So yeah, it seemed to help one person, but are you really moving the dial and putting the systems in place that you're able to assess the validity and the actionability of these different interventions is a challenge. And frankly, most systems are not designed to retrospectively evaluate the effectiveness of what was done, because that's not what you're getting paid for. I mean, for EMRs, it's making sure you get billed for what you did, not evaluating prospectively how effective these interventions were. So that's going to be a challenge. But sometimes there's also an issue. I mean, social determinants of health. We know that there are a lot of associations with higher costs, but the challenge is who's responsible for it? We did a survey where we talked to interviewed or surveyed about 600 physicians, I think, and asked them, would this make a difference for your patient population? And almost all of them said yes. If we can address things like transportation or food or housing or jobs or any of these things, my patients would get better care. And then we'd say, so now is it, whose responsibility is it? And their answer is, well, it's not mine and it's not my office's. So somebody else should take care of it. But again, it goes back to that, how do you create a business plan around it? Because a lot of these interventions don't see a positive ROI in the short term. And so how can you start to put in the necessary infrastructure and figure out what works? Sometimes, though, you just start with what the problem is. I'll use another anecdote from an ACO. And they said, we've got a major problem with diabetics. And we've got a high rate of diabetes, and then we've got a high rate of them admitting to the hospital. And so they said, what happens is every time we go to the hospital, we have a conversation. We say, you need to change your diet. We give them all sorts of guidelines and recommendations and things like that. But then they would end up back at the hospital. So what they found out is they made two changes. The first one is they realized that, first of all, everybody was getting discharged with home health care. And what would happen is that when they were getting discharged to home health care, they were actually never training the caregiver that was going to be with them after home health stopped. And so they said, well, let's bring in the caregiver and start to do that so we can eliminate some home health care. That's a big cost savings. The second one is let's proactively teach the caregiver that, so in this case, it tended to be a family member that tended to be cooking the meals. And as soon as you stopped talking to the elderly parent and talked to the child who was cooking all of the meals and said, this is the diet that your mother or your father needs to follow, turns out that they were very willing to change the diet. And I mean, it was a very low-cost initiative, but it had a direct impact, and they were able to save significant money from those two things, just reducing discharges to home health and training the caregiver on how to cook for them. But it's how do you identify those and actually validate that they were successful over time. But look where those problems are, and you don't have to have a high-tech solution to find those once you know it's there. Sometimes it's just talking with people to figure those out.
Mm-hmm. So Tim, are you seeing that kind of an approach from some of the folks you work with? Are they looking at things that way, or is it a little too far out yet for them to consider those?
I think it really depends. I mean, certainly there's some that are engaging from that perspective. I mean, it's how do you to continue to figure out ways, depending upon who you're serving, you know, in a large integrated delivery system where you're dealing with literally all those different environments, everything from ambulatory surgery centers, you know, to skilled nursing, to home health, to all the different moving parts, and then you deal with the realities of the fact that each one of those particular organizations has even different billing and coding rules and regulations and a variety of different scenarios on that side. Then you've got the reality of patient financial responsibility, which is again a part of that scenario, and engaging with those patients not only on, you know, how they're approaching, you know, both the cost of managing care, but really getting into that process and being more effective. So physicians, I think, and clinicians are certainly challenged with respect to trying to balance the difference between, you know, how do I manage both my fee-for-service, how do I engage from a quality perspective? How do I report effectively? And, engage my patients to be a part of the solution as opposed to, just continuing to see readmissions and seeing them continue to decline from a health perspective.
Mm-hmm. Are we seeing also a move towards maybe the employer group saying we're going to be running these, we're going to focus much more on holding groups accountable, direct contracting? We saw the GM, Henry Ford Health Systems, obviously Boeing with Providence and some of the others. Mm-hmm. And I think, David, there are actually more individuals covered in ACOs and commercial lives than there are in Medicare and Medicaid. Is that right? Or is that going to be maybe the driver?
Yeah. So I would say that it has not been yet. There's 3 conditions that have to be met for an employer to make this make sense. The first is they need a large population, because if you've got a few hundred employees, it's just not big enough to go and directly contract. It's not worth the time of the provider to go and negotiate for that. The second, you need concentrated lives. So if you're a company that works in all 50 states, you just don't have any single market where you can go and negotiate that. So you need a large number of lives in a concentrated area. And the third, you have to have both the willingness and the technical expertise to be able to go and work with the provider to do these direct contracting. It's more common to work this through a TPA as part of a self-insured process and say, let's just create a narrow network around a single provider and create some incentives for that provider to provide, certain, to meet quality or cost benchmarks and maybe even enter into a shared savings agreement. But there are not a lot of employers that are out there. The other challenge that we've heard, and this is, time and again, is that the benefits folks are really worried about making their employees unhappy. And so typically what we'll see is that they will offer this as a model, and it might be cheaper than going with the standard offering that's been there. You could go to your standard PPO network, or maybe you go to this new model and see how many people actually choose self-select into a narrower network model or to an ACO type model. Certainly, I think we've seen surveys where employers are very interested in this. They talk about it. They say it's somewhere in their strategic plan, but it just hasn't panned out quite yet. And I think it's just because it's a pretty daunting task, and it's still just the mentality that we can't make the employees unhappy, and there's always that threat.
Is there an opportunity, perhaps, I don't know, Jay or Tim, if you maybe will address this one, to flip that on its head and for the providers themselves to say out into their community, why don't we bring together all of you as an employee group and bring a bunch of employers together and aggregate the lives that way from that side to make it easier for the smaller employers to do something? Any thoughts? Or David?
Yeah, I think it's the challenge that I've seen organizations that have tried to do this, and there are ones that have been more successful, but whenever you try to bring in kind of different groups, you grapple with the problem of people, where they say, yeah, we're aligned on 70%, but that 30% is really important to us, and we're going to go our own way and do our own thing. Mm-hmm. And I think that's the challenge, where it's rarely do you have a sufficient volume of employers that are really aligned to the point that they can go and negotiate together. This is the same thing that you see with ASOs or TPAs, where they try to bring together enough lives that they can go and negotiate better rates for these self-insured plans. But everybody wants their own network. They want their own benefit design. That's the challenge. Is people aren't ready quite for a standardized product offering that you can then start really negotiating heavily against.
Mm-hmm. Any other thoughts, Tim or Jay, on that?
I still think that there's a lack of knowledge and understanding on the part of the employee/patient. I've actually seen letters that have gone out to employees and say, hey, you're now part of an ACO, and it attempts to try to describe it. I think, but to the average person, frankly, it probably doesn't mean much, and they're not really sure what the true impact is. And if their doctor, who's still a trusted resource, right, cannot explain to them the benefit of them doing that, I think it creates a challenge as to, okay, so why should it be involved in this?
Mm-hmm.
Yeah, I would concur. I think that not only, I mean, the patients are certainly with the growth, continued growth of the consumer payer, the patient financial responsibility continuing to grow 10, 11, 12% annually. The patients have been, I think more in line with kind of adopting that side of really their involvement in the care process. Adopting, becoming part of the payer environment. But as you shift accountability, especially to those patients that are high risk, the Honda patients as an example, how do we incentivize them? What are the programs that the accountable care organizations and others that are getting creative around what incentives, other than potentially some reduction in their cost of care themselves by getting involved in their disease state and taking ownership around some of those accountabilities. We talk about value-based reimbursement to clinicians. How can we drive that to some value-based, reimbursement and/or incentives for patients that are going to be able to get involved in that process and actually become part of the care plan itself?
And I know.
Yeah, I think consumerism is a fascinating dynamic. We know that patients that are activated, so that are actively involved with their care and their care treatment plan and self-monitoring and the like, have better outcomes at lower costs. The problem is that when you ask most patients if they want to be activated, do everything that's necessary, very, very few actually want to do it. And we look at those with the, the patient portals. And, you've got these patient portals, and every EMR has one, and then you look and you've got less than 10% of people who even sign up for it, let alone ever log in for it. And I think this goes back to one of the things that was mentioned earlier about the building the services around the needs as opposed to building a product and saying, go and use it. How do you make it easier for the patients? And we've seen this with like Oscar Health starting to put out from the insurer perspective of these tools that are actually supposedly, I haven't used them, that are actually intuitive and useful for the patients to use. An example I think of is Amazon. Amazon transformed shopping because it made it easy. And how many of us, either directly or somebody in our family, has accidentally bought something on Amazon? Basically all of us at one point or another has made an accidental purchase. How many of us have accidentally gotten preventive care or accidentally had an engagement with the healthcare system that actually was so easy that it just happened? We need to aspire to that as a healthcare system. We need to say that we want to make it so easy for patients to engage with the system in the appropriate level, at the appropriate time, with the appropriate person, with the appropriate information available, that they prefer to do that rather than going and calling somebody online or calling somebody and setting up an appointment and skipping work to go and do that. If people are more willing to skip work than to do something that's convenient, we're not there yet. So we've got a lot to aspire to on the consumerism side.
So speaking of Amazon and what you just brought up, are they the new front end for healthcare ultimately? Is that going to be the simple way to go on and order your drugs and they've got an ACO on the backside of themselves or something?
I wouldn't predict so. I would say that they've got some part of it, but they've focused on shopping, and I think there's a fundamentally different mindset around patient engagement than there is from shopping. There's certainly things you can learn from them, but it's like, hospitals have learned a lot from the hotel industry and the hospitality industry and say, we've picked up things and we can do better. So I think there's a lot that we can learn from Amazon. But the Amazon and the Berkshire Hathaway and the JP Morgan endeavor, they don't know what they're doing yet. They haven't announced anything. I'm sure they've got a lot of ideas, but I don't think that that's going to be necessarily the future of healthcare. But I hope what it can do is drive people that understand the nuances and the challenges and the difficulties in there to maybe it'll light a fire under them and say, now let's figure it out for real this time, instead of just putting another little Band-Aid on the wound and not fixing the underlying problem.
Yeah, well said, David. I think as it relates to the consumer transparency, as we've been educating folks on MIPS and the quality payment program, it's been interesting. Most clinicians are aware, of the Physician Compare website where Medicare is doing a star rating. But very few of them, as we're sharing with them that what they're doing from a MIPS scoring perspective, actually putting the aggregate MIPS scores for all clinicians on the Physician Compare website. And so then it goes to not only do I need to evaluate potential penalties and/or incentives, but I need to be concerned about public reputation and how if I have a low score and avoid avoid a penalty, how does that look to someone else who, I have a score of 15, they may have a score of 75 or 85. And as we move down this road, I mean, I think we're the only industry where consumerism doesn't have an appreciation for which providers are providing the most optimal clinical outcomes at the best price. And certainly from a data perspective, we likely could make that information available. But where's the market going from that perspective? And certainly I think that as I think through consumer transparency, I think that, not to be altruistic, but ultimately I think we all win when we can get to that level, because that way we're able to drive something that has gone from, we've created this world of through a fee-for-service market to where you really don't know. Even in many cases, patients over the years don't know what they need to pay. They don't know, should they ignore their first bill? All those different scenarios, right? So I think that this consumer transparency is a really critical, important part of the next phase of this, because it can change the way that healthcare is purchased, and ultimately, and therefore, there has to be behavioral change behind it to be able to facilitate it and make it work and make it productive.
Yeah, and Secretary Azar has put that as one of his priorities, is getting transparency out there for cost and quality. And I don't know if I'm convinced that it's really going to drive a lot of patients to do things differently, because they're not well positioned to interpret it. But care coordinators that are trained in this, if people go to those, it will be phenomenal for them. If somebody has a care coordinator that they work with and say, I need to do this, and they're like, let me help you and tell you who you should consider, that radically transforms things, where you have people that actually know how to interpret the data, that now have access to the data, that are able to direct people to better care.
Got it. I'm thinking about, Amazon, and I go on there to buy something. The first thing I say is, okay, give me anyone 4 or more stars, and it's Prime, and it's cheap. And then, as you said, Tim, sort of, why couldn't we just do that? We do it with everything we purchase through Amazon. Why don't we just have our doctors up there like that? Is that feasible?
I think feasibility and adoptability, again, are two different scenarios. I think right. So feasible from the perspective of being able to make that data available. If I need a hip replacement, where in my area is there data on good quality, high outcomes as it relates to hip replacement, and who has been able to provide that at a reasonable or low cost? I mean, certainly from a feasibility perspective, that data could be certainly available. But then it's driving it from the perspective of really facilitating it. As David said, can consumers make those kind of choices? We've got a long way to go to be able, I think, to change the paradigm of how healthcare is both purchased and ultimately delivered.
So I guess what we would want to do then, based on what you said, Dave and Tim, and they possibly think the same way, is actually make that data available to the person billing the CCM code, to then make that referral to the right place and use that data for them, because the patient will trust them more?
Yeah, or that they're trained to do it and trained to use the tools. And it's the same thing where, we'll go to our accountant to ask for a tax question, even though maybe theoretically we could go and read all of the IRS notices and try to figure out ourselves, but we don't, because we go to the people that are trained for it. And I think that's actually an area of the workforce development, where people that are trained to use the data and help people really successfully and efficiently navigate through the healthcare system, there's just a lot of opportunity there.
Mm-hmm. So we're coming up on
I agree that...
Go ahead,
I'm sorry.
Jay. No, go ahead, Jay.
I was going to say that I agree with the opportunity, and maybe in some ways I'm a little bit more cynical on this topic, because the interaction that a patient/consumer has within healthcare is very different from a shopping experience. I mean, typically if someone is sick or a loved one is sick, you have a different motivation, and in some ways what that patient/consumer wants is, they want information, but they want ease. They don't, they go and they get referred to 3 or 4 different specialists because of a condition they have, and they show up at each of those sites and they have to fill out the clipboard 4 or 5 different times. That's the kind of frustrating, annoying thing that a patient/consumer deals with every day, not, gee, I'm going to go to some website or some portal and try to find the best deal on an MRI. I just don't think that that's practical or realistic.
Sure.
So we're getting too far out in front of ourselves with that kind of stuff. We got to go back and do the basic blocking and tackling.
I think so.
Yeah, that makes a lot of sense. So,
Well
you
said.
know, go ahead. Oh, I thought someone said something. So if you think about this, then maybe perhaps Jay, you can start, and then Tim and David, what final words of wisdom would you give to the healthcare community as they say, we're stepping in, how quickly, value-based care is here? What would you be telling them?
I mean, what I would say is a lot of what we've talked about today is that we have to do a better job of sharing data that ultimately will be information that can be exchanged between all the participants. We ended up talking about the consumer. They're obviously very important in this, as well as multiple providers in the health plans. And so until we get those connections well-oiled, I think we've got some challenges ahead of us.
Mm-hmm. How about you, Tim?
Yeah, I would concur with that. I think that the challenges are clearly there. You know, being able to look more holistically across the entire even revenue cycle workflow and the clinical workflow, engaging earlier in those environments so that we can actually have an appreciation for what we're doing. Is there clinical defensibility? How does that both impact outcomes? How does it likewise impact reimbursement to my practice or to my health system? So I think it's really important to look holistically, not just at one particular episode or one particular environment, but looking across that entire clinical workflow and revenue cycle workflow, getting everyone involved as possible, because certainly fee-for-service and value-based, the shift from volume to value is here. It's happening, but it's going to take a long time. So you've got to be able to make sure that even with your focus on value-based care, that you're still focused on, maximizing your fee-for-service revenue, because you have to be able to do that and able to survive. So I think it's really managing both of those worlds. They're both critically important, but you can't take your eye off the ball on one and focus on the other. It has to be a dual-threaded approach.
Mm-hmm.
So Bill Gates said that we often overestimate the amount of change that will happen in 2 years, but we underestimate the amount of change that will happen in a decade. And I think healthcare next year and the year after will look a lot like it is today, but over a decade it will look radically different. And so organizations need to realize that we really are in the midst of a fundamental transformation of the healthcare system. And if you don't get involved with it, you're not going to have a say in what it actually develops into. And so don't ignore the slow change in the short term for a lack of a longer term major change that will happen. Be aware, be involved, and help make that difference.
Well, fantastic. Well, thank you, Jay and Tim and David. Great conversation. Really appreciate it.